Hi, welcome to my channel again. Today's topic is differential diagnosis of chronic headache and pain. Now, one thing I would like to tell very clearly here that headache is a very big topic. It is not possible to tell the whole story here. This is just a clinical synopsis of the chronic headache only, not acute headache. Okay? There is International Headache Society for Understanding Headache. It probably means that headache is not always understood. So don't hesitate to take other expert help if not clear about the diagnosis before simply treating. Treatment without diagnosis is actually delaying treatment and uh, that may invite problems. So best thing is diagnosis first. Okay. Coming to the common causes, as I mentioned, there are a number of causes of headache, but we will be covering the common causes of chronic headache only. Okay, fine. Now, the topics include migraine, trigeminal neuralgia, glossopharyngeal neuralgia, cluster headache, tension type headache. Doesn't mean the headache because of tension. The SUNC, short unilateral neuralgiform pain, sinusitis pain, TM joint pain, cervicogenic headache, occipital neuralgia, burning mouth syndrome, post-herpetic neuralgia, paroxysmal hemicranial pain, and hemicrania continua, giant cell arteritis, post-stroke pain, dental causes, pain due to poor eyesight, medication overuse causing headache, and intracranial reasons like intracranial bleed, space-occupying lesion, infection, trauma, metabolic reasons, etc. Coming to the first one, migraine. The pain pattern in migraine is typical. Patient reports lack of sleep, stress and anxiety, takes frequent caffeine, skips the meals, and the typical trigger is physical exertion, lack of sleep, stress, caffeine. All these things they lead to migraine in these patients. And the presentation is that it is more common in women, generally unilateral. It is throbbing type, lasts 15 minutes to 3 hours, usually happens in the frontal, periorbital, and temporal area. Invariably, there is an aura, either visual aura, auditory aura, or taste aura. There is likely to be photophobia and phonophobia, and likely to have nausea and vomiting. If these things are there, one should consider migraine. Second is trigeminal neuralgia. Now, trigeminal neuralgia are basically of three types. Classical trigeminal neuralgia, which is caused by pressure on the trigeminal nerve. This nerve provides sensation to the face. Secondary trigeminal neuralgia, in which it is caused by another medical condition or problem, intracranial reasons. And third is idiopathic. This term is used when the cause is unknown. As you can see in the picture, the green one is the V1 or ophthalmic zone. This is V2 or the maxillary zone, and the mandibular division spreads right from temporal up to the chin. Okay, so V1, V2 and V3, these are three zones. According to which area is involved, it is called V1 neuralgia, V2 neuralgia or V3 neuralgia. The pain is unilateral, current-like, sharp, shooting, severe pain and episodic pain. It is hardly continuous. It is precipitated by chewing, talking, touching the face, shaving, cold atmosphere, even at times wind touching the face causes this. And pain pattern depending on the division which is involved. Most common is V3, then V2 and then V1. Glossopharyngeal neuralgia, another neuralgia which is because of the glossopharyngeal nerve being irritated, and the presentation is typical. The patient has pain which is unilateral, current like sharp shooting because it is neuralgia, severe and episodic, but it is in the ear and in the throat behind the tongue. Typically it is in the ear and behind the throat, right? So this is how you can differentiate between the trigeminal and the glossopharyngeal, and it is precipitated by swallowing, not talking. All right. Cluster headache. Cluster headache is more frequent in men, may have family history. It is unilateral severe pain in face, mainly around eye, lasting minutes to hours, and there is a autonomic symptom. What is it? Ipsilateral ptosis. Can you see this? Then meiosis, the pupil becomes small. There's redness and injection of the eye, tearing of the eye. There's eyelid edema, and there is a rhinorrhea or nasal congestion as well. Tension type headache. Here, the pain pattern is band like. Pain is like a band squeezing the head. Usually, there is family history. Tight band like pain is there. It improves with activity. It can remain for hours to days, and light and sound sensitivity may be there. Either of it, not both. Shunt. What is shunt? Read the red letters. Short-lasting unilateral neuralgic-form headache attacks with conjunctival injection and tearing. Again, autonomic symptoms are there. All right. So here you can differentiate from other. Whenever there is an autonomic symptom, then there are 3 or 4 pain patterns which are common. This is more frequent in men. There is a unilateral face pain, short-lasting, consecutive, rapid attack, typically less than 4 minutes with conjunctival injection and tearing. Short-lasting, right? So less than 4 minutes. But there are consecutive rapid attacks. Short stabbing, moderate to severe pain, and it responds to lamotrigine. Orbital, supraorbital, temporal, these are the various types. This combination, this combination, this alone, this alone, this alone. All right. So, shunt. Now, next, sinusitis headache. Now, this is very common. We have learned through MBBS. All right. That there is a history of sore throat, there is postnasal drip, bad breath is there, thick colored nasal discharge will be there, difficulty in breathing through nose, they are mouth breathers, all right, and there is a loss of smell or taste, fever might be there, constitutional symptoms might be there, and there will be tenderness of the sinuses, all right. So that will differentiate. You generally it is bilateral. Temporomandibular joint pain. Typically, the temporomandibular joint is in front of ear where there is a tenderness and pain. Pain is in front of ear. Movement of the joint will be painful. There will be local tenderness and crackling at times. And mouth opening will be painful. Simple, not a difficult diagnosis, but you should keep that in mind. So ask accordingly. Cervicogenic headache. Again, a common headache, but generally missed. We always think that whenever there's a face pain, we try and find out the reasons in the face. But sternocleidomastoid or strap muscles in the neck can have pain spreading to back of the head, top of the head, frontal region, around the eye when the triggers develop in these muscles. So pain around eye and temporal area, at times top of head, pain in the occipital area behind the ear, and there will be tenderness of the muscles, sternocleidomastoid or other neck muscle. History reveals that pain started in the neck. Pain is of dull leg type, not neuralgia type, and there will not be autonomic symptoms in general. What are autonomic symptoms? We talked about it. There will be redness of eye, tearing of eye, nasal congestion, rhinorrhea. All right. So these things are autonomic symptoms. Occipital neuralgia. Again, because of the irritation of the nerve, but it is on the back of the head, right? Occipital nerve comes from here and goes up, okay, from the spine, upper spine, and it goes to the back of the head. All right. Pain is typically felt in the upper neck, back of the head, scalp, and may spread to forehead. May spread to forehead. Behind the eyes and ears also it can spread, and usually it is on the one side of the head. Upper cervical spine facets may be the source of pain apart from the occipital nerve itself, right? Burning mouth syndrome, another clinical entity which keeps the clinician baffled. Patient says, I feel burning in the mouth, essentially the tongue. So burning, scalding and tingling in mouth, especially in tongue. It does not spread outside mouth. History digging may give clue to causes like infection, acid reflux, vitamin deficiencies, depression, diabetes, medices. These are the various reasons which might give rise to burning mouth syndrome. Now, post-herpetic neuralgia of the face. Here, the pain is typically felt in one branch of the trigeminal nerve, either V3, V2, or V1. Rarely, 2 or 3 may be involved. There is a definite history of herpes. Pain is typically neuralgia type with more or less continuous nature. There is hyperalgesia and allodynia. What is hyperalgesia? A non-painful symptom, rather uh, mildly painful trigger feels more painful. And allodynia, something which is not painful, that is touch, is felt as pain. Okay, so these two terms you must understand when we talk about pain like PHN. Paroxysmal hemicranial pain and hemicrania continua. This is a, I mean, a type on, it's a kind of, you say, types of one type of pain group. All right. No family history, more common in women. But hemicrania continua has a unilateral continuous headache with episodic stabbing pain. And in paroxysmal hemicranial pain, as the term says paroxysmal, it is only few minutes attacks are there. But otherwise, the pattern is similar. It is ipsilateral, more around the eye and above the eye. There are autonomic symptoms which we discussed, and this is the kind of area which is shown by a patient.
Giant cell arteritis or temporal arteritis as it is called is a typical pain syndrome seen because of the inflammation of the artery. So it is caused by inflammation of the temporal artery. Typically the age is above 50. There is a headache, jaw pain, vision problems. Artery may be tender. That is very peculiar. The artery may be tender. It differentiates from the TM joint being tender. All right. Then there's a close link of this with polymyalgia rheumatica with widespread pain across the body. There will be constitutional symptoms like fever, night sweats, fatigue, depression, weight loss, because basically it's an inflammatory disease. Post-stroke pain. Patients who develop stroke later on develop pain in the area of stroke. That is called post-stroke pain. So there will be history of stroke. There will be pain and sensory abnormality in the affected part. Presence of sensory loss or hypersensitivity may be there. There will be painful spasticity at times. Shoulder pain will be common. Persistent headache will be common. And other painful musculoskeletal conditions may also be there in the given area. But essentially, there will be history of stroke. Certain other chronic headaches, which require mention. Poor eyesight headache. Always ask for pain related to prolonged reading. Sinus headache. This we have covered. Press the sinuses, take the history of related things as mentioned in the slide above. There will be some dental causes. So there will be pain on eating, pain will be non-neuralgic, non-autonomic, local tenderness on the tooth will be there. Sometimes medication overuse can also cause headaches. There will be some intracranial reasons like intracranial bleed, space occupying lesion, infection, trauma, metabolic reasons which can cause headache. But there will be signs of raised ICP. There will be other constitutional symptoms. There will be lateralization signs. History of trauma may be there, or presence of accelerated metabolic disease may be there, right? These diagnoses must be ruled out before embarking on the treatment because these are dangerous diagnoses. They need immediate attention. All right. So don't miss these. You may miss migraine and patient may suffer for a few days and later on you can treat, but you cannot afford to miss all these things. All right. The clinical pulse, the take home message is if there is a history of trauma and accident, think about intracranial reasons, cervicogenic headache, because whiplash injury can be there. If there is a signs of infection, think about intracranial infection. If there is a history of uncontrolled metabolic disease, think about intracranial and ocular reasons. History of autonomic symptoms are there, like redness of the eye and lacrimation, nasal congestion and rhinorrhea, but no relation with eating and talking. Important. If autonomic symptoms are there but not related to eating and talking, think about sunk, paroxysmal hemicranial pain, hemicrania continua, or cluster headache. How to differentiate? Sunk is typically sudden and for 4 minutes. Postcranial paroxysmal hemicranial pain is for minutes longer than sunk. But hemicrania continua is a continuous pain, as the name suggests. In cluster headache, it lasts from minutes to hours, but it happens in clusters for few days. History of unilateral episodic neuralgia pain, increasing on eating, chewing, talking, shaving. Think about trigeminal neuralgia. If there is a history of aura before pain and there is a unilateral episodic non-neuralgic throbbing pain, uh, then think about migraine. There will be nausea, vomiting also. All right. And if the pain is starting from side or back of the neck, think about cervicogenic headache. So this covers the topic differential diagnosis of facial pain and headache. Of course, as I said earlier, this topic is extensive and I might have missed certain things. So the reader is advised to go into depth of this subject. But yes, this PPT will give you a clinical idea as to how to locate the important reasons of headache. Thank you very much. I hope you liked this video, and if you have liked it, then uh, click the like button, share it to your friends, and subscribe this channel to get further notifications of my next videos. Thank you very much. Thank you.